So, what are your thoughts on what may have caused a lot of the deaths last year?
Well,
It's a long topic, but
it's a long topic, a little bit complicated, and the observance for the past 2+ years, a number of male and female athletes, bodybuilders, figure fitness, physique competitors have moved on at a very early age of life. And the number one causation usually is cardiac. And when we think of cardiac, we think of heart attack. Now, heart attack's a general layman's term because there are multiple ways of having a heart attack. Some of the things, if we are stacking steroids, overdosing, doing huge pharmacologic doses of anabolic steroids, is it causes cardiotoxicity. It causes your good fats, called HDL, to go down, your bad fats, LDL, to go up. You're more likely to have necrotic, fibrotic changes of the vessels that clog up the vessels. It remodels your heart. It makes the heart bigger. It puts more pressure on the heart. So all these changes in the heart can create a pathologic rhythm that we call arrhythmia or dysrhythmia. So some of the athletes may have a heart attack, but the heart attack may have been because of abnormal electrical conduction through the heart, causing an abnormal rhythm. The abnormal rhythm can cause the individual to have cardiac arrest, which means no more heartbeat, or it can be from flipping a clot from one of the coronary arteries, the most likely one called the widowmaker, left anterior descending artery is the major one. And if you obstruct that, and it's full of plaque, and it flips off a clot to that part of the heart dies. Enough of the heart dies, you die and expire. So there are multiple factors and pathologies that go into a heart attack. So the other part of that is that athletes don't follow certain blood tests that they should follow. And I normally tell them, not that I'm promoting anabolic agents for the purposes of performance enhancement or for aesthetic purposes. If you're genuinely and symptomatic and we test you and you have deficient hormones, then we try to optimize that. But along with that, you have to follow the lipid parameters, the liver parameters, the blood count, because hormones long-term, testosterone and their anabolic derivatives, increase red blood cell formation and hemoglobin hematocrit. They carry our oxygen. It's great if you're anemic, but if you produce too much, then you get what they call polycythemia, erythrocytosis, too many red blood cells. It's like, now it thickens the blood, it's like Pennzoil running through your vessels. It thickens the blood like Pennzoil, you're more prone to clotting events. Deep vein thrombosis, blood clots in the legs, and blood clots floating up to the lung, and to your heart and your carotid arteries to the brain. You're more prone to heart attacks and strokes and abnormal rhythms when you have Pennzoil running through your vessels. So
is donating blood enough to let people keep doing heavy cycles?
That's one of the things, one of the therapeutic regimens that I recommend athletes as their blood counts get higher to donate or do a therapeutic phlebotomy to unload some of the blood so we get the blood count down. However, if you're doing heavy cycles, keep in mind you're still potentially doing damage to the vessels themselves, the heart itself, or the valves. You get enlarged heart, usually a left ventricle. You can, if it gets, the heart called cardiomegaly gets too large, it can fail.
What causes it to enlarge? Just the heavy doses?
The heavy doses. It stimulates, again, the heart is a striated muscle. It's a muscle, like our biceps, like our triceps, our quads. It enlarges too, just like our regular muscles do. However, the heart, in proportion to what it can pump, cannot keep up with that activity. Coupled with strenuous exercise, heavy lifting, if your heart is already under a lot of stress, enlarged, sick, in other words, cardiomyopathy, that's a sick heart. Coupled with strenuous exercise, that can cause you to flip off the abnormal rhythm, causing you to go into what they call AFib, aflutter, other dysrhythmias that can cause cardiac arrest When you have no heartbeat, you have no blood flow. That's called expiration.
Well, so in line with that, does the act of gaining weight and putting on muscle inadvertently stress the heart? Is there a point where you can only put on so much muscle before your heart has to grow to keep up with it, and now you've jeopardized your own health?
True. When you're working out and taking anabolic androgenic agents, the idea, of course, is to put on more lean mass, decrease body fat. The body fat mass index goes down. However, your heart can only keep up with so much mass. So what will happen is, if the heart is overstressed, it goes into heart failure. And heart failure is a causation of heart attack. So when you're in heart failure, the heart, can't pump blood around to oxygenate it. If the heart fails, then you start getting water retention in your legs, your lungs, and you get congestive heart failure, is what it's called. And then congestive heart failure can cause pulmonary edema, fluid in the lungs. Then you can't breathe as well. What some athletes do is they'll take a diuretic, like furosemide, diazide, hydrochlorothiazide. Those are very common to unload the fluid that they may be developing from heart failure, one, or two, because they are not taking an estrogen blocker adequately and retain too much water from the estrogen. The heart can only take care of so much duty before it fails.
Do you find that hormone replacement therapy levels, can they trigger stress to the heart? Or is that something within like a safe range for the body?
Good question, because to differentiate therapeutic optimizations with HRT, hormone replacement therapy, versus pharmacologic PED levels, there's a huge difference. In my practice, we evaluate where your hormones are deficient, and we optimize to a normal physiologic level, which is actually better for the heart, because individuals who are hypogonadal, meaning low testosterone, have actually worse cardiac function. Again, the heart is a muscle. So when it doesn't have adequate testosterone anabolic stimulation, the heart doesn't work as effectively and efficiently, and it can fail earlier. And individuals who have very low testosterone have actually a more abnormal lipid picture. They have higher cholesterol and higher LDL and lower HDL. You need adequate, not huge, large doses of anabolic agents, but you need adequate doses of testosterone, okay, to metabolize cholesterol. If you exceed that level significantly, you reverse the good benefits of testosterone replacement therapy. Your LDL skyrockets, your HDL good fat plummets, and you're more prone to CAD, coronary artery disease.
Can someone compete in bodybuilding and go a long distance if they come to someone like you for guidance through their heavy cycles? Or are they still playing with fire?
Well, as I mentioned before, Neil, I can't condone
Right.
PEDs, performance enhancement drugs, in terms of large pharmacologic doses. My role is to educate the patient athlete. If they let me know, what do you plan on doing? Because I'm not going to stop you from doing what you're going to be doing. But I can educate you on the pros and cons of what you're going to be doing and stacking whatever gear you're stacking and whatever doses. And if you are, do it wisely, and here are the reasons. So my role is more education. And in answer to your question, can they prolong longevity of their career? I would say yes. If you do it, at least do it as wisely, smartly as possible.